Hi everybody, Tom here with Protocol of the Day. Let's talk today about hypertensive crisis. I'm going to talk about the pharmacology a little bit and some physical presentations of a hypertensive crisis and more so how to differentiate this, like I said, from other presenting issues. So by definition, what is a hypertensive crisis? So we see a patient presenting with an elevated blood pressure as defined as a diastolic above 120 or a MAP above 150. But more importantly, they are showing some type of symptoms along with this. So they're showing nausea and vomiting, headache, visual disturbances, chest pain, discomfort, even shortness of breath sometimes. So what's important to remember with someone that's presenting with a hypertensive crisis is people live at a baseline with hypertension, but what makes this so much more that they either call 911 or they're having these symptoms? That's the big question that we always have to keep in the back of our heads as we are assessing these patients. So if we have a person who is an uncontrolled hypertension patient, they haven't taken their medications, there's been some type of change in their medications, there's some type of illicit drug use involved, all other things we need to be considering when we're assessing these patients. But going back to the vital signs, so we are assessing their blood pressure. We see that they have a diastolic over 120 or a MAP of 150. But if we don't have a fancy dancy monitor like this that tells us what our MAP is, how do we figure out our MAP? So there's multiple formulations and calculations that you can use to figure out your MAP. The easiest I find is, I call it the single, double, divide by 3. Single, your systolic, double, your diastolic, divide all of those by 3. That is your MAP, so your mean arterial pressure. So think about the definition of mean arterial pressure. What is so concerning about a patient that is presenting with a blood pressure that is that high is, granted, their systolic is high, so that's dangerous enough, but it's more so their diastolic. So think about it. When their whole cardiovascular system is relaxed, so in diastole, that number is where most people's blood pressure is resting when it's actually contracting in systole. That's why the calculation of the mean arterial pressure MAP and keeping the diastolic is so important. So if you have the ability to trend with your monitor, that's fantastic. But otherwise, you're going to have to do the calculation by hand. But more importantly, when we see a patient initially during our presentation and we take our first set of vital signs and we see an elevated blood pressure that meet all the criteria, in order for us to initiate this protocol, we have to have 3 blood pressures meeting that criteria 5 minutes apart. So you're already 15 minutes into patient contact at this point before you are initiating this protocol. So this is something to keep in mind. If you are trending along those lines, you have to keep in mind that you're going to have to contact medical control, because we cannot initiate this protocol without. So if our patient meets the criteria for the blood pressure, they are showing signs and symptoms, we contact medical control and we are going to ask for 10 milligrams of labetalol IV. We're going to administer that over 2 minutes. So of course, after the administration of the medication, we are constantly reassessing vital signs, but the criteria to contact medical control again for a repeat dose is 10 minutes after the initiation of the medication. So the patient still has to meet the criteria for the blood pressures, still has to show signs and symptoms, and then with another call to medical control, we can actually administer 10 to 20 milligrams at this point. But if you've been keeping score, 15 minutes for the initial blood pressure alone to even initiate the protocol, and then another 10 minutes, we're pretty far into this contact. So the treatment for hypertensive crisis, once the patient meets the criteria, is pretty straightforward. It's 1 dose of a medication after contacting medical control. But what is more important are the criteria that we are going to withhold the treatment for this medication. And that's where a detailed assessment and knowledge of the medication and pathophysiology behind hypertension is critical. So one of the first criteria that we are actually going to be withholding labetalol administration is a patient that's presenting in congestive heart failure. So we know that the congestive heart failure is a backup of the cardiovascular system, and all of the mechanisms going on are actually a negative feedback loop that's going through, especially with the hypertension. So that is not the sole cause of what is causing the hypertension. The sole cause is the backup of fluid or the potential for heart failure, which is going on with that particular patient. So that's a compensatory mechanism at that point. So if we take out that compensatory mechanism, the patient's going to lose preload, they're going to get bradycardic, and they are going to decompensate on you. Going right along those lines, the other criteria that we are not going to be administering labetalol to a patient is any patient that's presenting in a heart block, because that's showing that there's some type of cardiac conduction delay or some type of failure within the heart itself. So by giving a beta blocker, which is going to slow cardiac conduction, is going to only further the symptoms of that patient at that point. Of course, a patient who is presenting bradycardic at baseline, because we have to be concerned at this point, because if we're going to be giving a beta blocker to a patient who, say, has a heart rate of 60 already, but they're hypertensive, they're compensating at some point. So we have to be careful not to knock out that cardiac drive. Pharmacologically, one of the reasons for withholding labetalol well is the patient that is presenting with suspected or known cocaine use. The reason that we are doing that is because cocaine is a very strong alpha agonist. So squeezing those blood vessels, if we give labetalol, for example, is both what they call a combined beta blocker. It has both beta 1, beta 2, and even alpha effects to it. So it's non-selective. It hits all of the cardiac receptors. So by blocking all of those receptors, the cocaine in a patient's system is uninhibited at that point and can actually make their blood pressure spike even further by further constricting the blood vessel. And because it also is a non-competing beta blocker, if you have a patient who is a long-term COPD patient, for example, and takes long-term beta 2 agonist, which is albuterol, and medications like this, you can actually reverse the symptoms of that. And while a patient is having a hypertensive crisis, they can actually go into an acute respiratory distress, and any medication you're going to give them at that point is not going to work due to the blockade of the beta blockers. And most importantly, the criteria that you withhold any type of labetalol use is a patient that is presenting with a possible stroke. And the reason being is a patient can present hypertensive, have vomiting, visual disturbances, all of the symptoms that are going through, but in fact, they're having an acute stroke or bleed. And the problem is they will be presenting as hypertensive and potentially bradycardic, showing that Cushing triad going on because of the increased intracranial pressure. So if we give labetalol at that point, we are taking out that compensatory mechanism, but more importantly, decreasing blood pressure in a stroke patient acutely will actually decrease cerebral blood flow and will actually increase the chance of more brain death at that point because it's not perfusing. Just like with certain patients where we allow them to be permissive hypotension, a stroke patient we actually allow to be permissively hypertension, and it's very delicate management that they do at the hospital with very quick acting medications that they can turn on and off to really titrate that blood pressure. We don't want to drop their blood pressure too extreme because it's going to cause that decreased cerebral blood flow. So to review, a patient in a hypertensive crisis has a blood pressure that is elevated, noted as a diastolic of 120 or a MAP of greater than 150, and that has to be sustained over 15 minutes or 5 minutes apart, at least 3 measurements. And once that patient is deemed to have that hypertensive crisis and not one of the other issues, congestive heart failure, potential stroke, some type of tox incorporated with it, we are initiating this protocol. And to review how to calculate a MAP, single your systolic, double your diastolic, add them together, divide by 3. Thanks for joining. Any questions, let me know. See you soon.